Nick was one of the authors behind the report Review of Quality of Danish Healthcare that came in 2013 spring, and Nick will try to put accreditation into that perspective. Please welcome.
Okay. Thank you, Jesper. Good morning, ladies and gentlemen, and sorry I can't do this presentation in Danish. So you have to bear with my English. As was introduced, I have two caps. I'm working at the OECD in Paris, the Organization for Economic Cooperation and Development, and I'm coordinating the Healthcare Quality Indicator program there. And I'm also a professor of social medicine at the University of Amsterdam. And actually today, I will be wearing both my caps in this presentation. I will first take the perspective from the OECD. I will look at Denmark, give you a little bit information about the things we found in the review we did at the end of last year, and give you my reflection on what that could mean for the accreditation program. Then I'll share with you some research results from an EU-funded study on quality of care in European hospitals. And then I'll come back to my recommendations to see to what extent the evidence and the knowledge that was obtained in this research project can be used for drawing some conclusions on how to proceed with accreditation. So, Denmark. Well, I'm from the OECD, who looks at the economic development. So I have to start with some facts and figures, and this is a reality that all OECD member states are facing at the moment. Basically, after a period of 15 years of continuous growth in the spending on healthcare, we see since the economic crisis in 2008 that in all member states there is a sharp decline in spending on healthcare, both public spending and private spending. And when you look at the average annual growth in health spending, you will see here that whilst Denmark is still amongst the countries that are the highest in spending, and where is Denmark? Here. You are spending as much as Germany and Canada, and are about on the 7th and 8th place in overall spending within the 35 OECD member states. But also Denmark is seeing in the past years the reality of a shrinkage in the spending. And the bad news is that will be there for the foreseeable future. So there will be pressure on all healthcare systems to think carefully on which you spend your money. Hence, you want to look at the performance. And these are some rough statistics that the OECD is using. And later this month, you will see this publication, Health at a Glance 2013. It will contain the most updated statistics on the performance of the various healthcare systems. Just some rough data. Here is a graph that gives the asthma hospital admission rate. Basically, we will look at the functioning of the primary care systems by looking at the rates of potentially avoidable hospital admissions. So we try to figure out how many patients with asthma, COPD, chronic heart failure, diabetes end up in the hospital, because if the primary care system would be optimally functioning, those rates should be rather low. Well, the good news is Denmark is doing reasonably well here, but you see there are countries that are performing better, and that is also clear when you compare your admission rate for chronic diseases on some other disease factor groups. When it comes to the acute care, your hospital sector, I can only congratulate you, because Denmark has the lowest 30-day case fatality rate for acute myocardial infarction of all the member states. You see here the good story is that in all of the countries we see a steep drop in 30-day case fatality rates, and I have similar figures for stroke. And Denmark is doing really well there. Even if I look more in depth and I make it patient-based and I look at total mortality, Denmark is amongst the best performance. The story is a little bit more blurred when I look at the cancer statistics. Denmark is doing well. You were not doing that well about 10 years ago. You seem to be catching up, which is good, but we can't still infer whether at this moment your cancer systems are strong enough to really put you at the top of 5-year survival rates for things as breast cancer, cervical cancer. Time will show, because luckily enough, those patients are at this moment still alive. We try to capture patient safety by looking deep into the administrative databases, and there are big discussions about these kind of statistics and about comparability, but the bottom line here is that if I try to find Denmark here, this is, for example, that in the administrative databases we look at the percentage of post-operative sepsis. And in this graph we try to make a distinction between total surgeries and abdominal surgeries. And of course the assumption is you will have a higher rate of abdominal sepsis, of post-operative sepsis in abdominal surgery. And that seems to be true in the most of the countries where we know that the databases are pretty good with a lot of secondary coding and things. And here the pattern of Denmark is surely not alarming, and you see it is quite comparable with the databases in the US, which at least for us gives us the idea, at least they have a grip via data on what's going on. Whether this would be the exact representation of the safety risk in your hospitals, of course, is another issue. When I tried to assess the patient experiences, unfortunately the Danish data are not comparable with what we were doing here, and there are lots of debates there too, but at least there is a core set of questions that countries now try to embed in their survey system, so to make it somewhat comparable. This is about patients being of the opinion that a regular doctor was spending enough time with the patient during the last consultation. So overall, I'm bringing you good news. Denmark is doing well. It's about the top 20% of the countries on most of the quality parameters. That's good. But you are facing the financial pressure, and you are facing, like all the industrialized countries, the growing burden of a multi-morbid population that is getting older. So how is your system reacting to that, and are your quality systems also adapted to that reality? Well, that was the reason why the Danish government asked the OECD last year to do a review of its quality strategies. And I won't repeat all of the recommendations, because we looked at lots of different areas. But this kind of summarizes the main conclusion. The main challenge for the Danish healthcare system will be to make the many different quality monitoring and improvement mechanisms part of a coherent quality assurance system. I have to compliment your country that you were able to introduce a new governance model. You went from 13 to 5 regions. I have to compliment your country that you rationalized the hospital system. You had a hospital reform system in place. I have to compliment your country that you have a Danish quality model with a lot of activities and a lot of accreditation activities. And I have to compliment your country that you have a well-elaborated patient safety strategy with an association who is carrying it, an adverse event reporting system, and a huge involvement of the various stakeholders. All that is true. So we start from the premise that Denmark is one of the more developed countries when it comes to quality systems and monitoring. However, when you try to see the coherence between the various activities, there are still gaps. The standards of your ministry, of the Danish Health and Medicines Agency, the standards in the accreditation program, the operationalization in the 5 different regions, the link between the measurements, huge efforts on the clinical side, great clinical registries, possibilities for data linkage with administrative databases, but less developed data systems when it comes to home care and long-term care, and when we look at municipality level, and still more piecemeal information on the level of primary care. Hence the recommendation, a lot of good things, but how do they link together? And that was the second part of the main message. Is it underpinned, or it should be underpinned by a modernized primary care sector? Does that mean that your primary care system is dysfunctioning? No. But we see in other member states that in reaction to the burden of chronic diseases, multi-morbid population, linkages with social services, and the responsibilities that are now on the municipal level, there should be a kind of rethinking of how you position primary care. Can that still be done in small practices, solo practices, or do you need larger entities and at least cooperation forms that are more consistent with a patient-centered, continuous way of providing care? Hence, some very tough recommendations about, after reforming your hospital sector, more rational, less hospitals, now really looking at how that links with your primary care sector. And stronger monitoring of clinical practices in hospitals and of health inequalities. What we mean there is especially the link to individual professional performance. You have a lot of systems in place that look at hospitals as a whole, but the individual responsibility, as reflected in how obligatory is your continuous medical education for doctors and nurses, how is that linked to recertification? Those mechanisms are, again, compared with other member states in the OECD, less developed because your system is depending very much on the functioning of a Danish quality model and what it brings you. So I'll now skip the health inequalities, but that was not a request of your ministry. We looked at how good are your databases in actually capturing that. And we saw that a lot is captured, but improvements can be made, especially by having linkage with the education level, socioeconomic status in your databases to actually disaggregate your quality indicators by socioeconomic groups if you really want to know whether there are inequalities in the use of your healthcare services. So this was the kind of overall recommendation from the OECD to your Ministry of Health, where we try to think about what the consequences could be for accreditation. I give you some generic ones. It's clear the present model is mainly focusing on hospitals. It would be good to know what is the potential of having accreditation for home care, nursing homes, and especially for providers in your primary care system. What is the alignment with the policies on patient safety and with performance indicators? And I see already that there's, especially with the indicators, there is a lot of attempt for alignment, but of course that takes continuous work. What is the alignment with the regulatory-based control mechanisms, such as the inspectorates and supervisory bodies? Here again, this is not a specific Danish problem. We see this everywhere, and especially now in Scandinavia, you see that on the national level, the boards of health are turned into more agencies, authorities. Sweden has done the same, Norway is doing the same, but that means that you have at the same time a kind of inspectorate function and you have a accreditation function. How do they relate? Are they using the same standards? And where is the focus? Is the inspectorate more on the safety issues? And is that from a public protection principle, what they are doing? And then how does that relate to the quality improvement function that the accreditation model has? Alignment with population-based health system governance models and policies. There again, if you optimize the functioning of hospitals, how does that relate to the functioning of the health services in the whole region? So to what extent do you include standards in the accreditation of your hospitals, your pharmacies, future home care, primary care, that also look at the alignment of those services with the rest of the local healthcare system? Again, all countries are facing that challenge, but it's logical consequences of the way you now try to structure your healthcare system. And last but surely not least, how will you reconcile the summative and the formative functions of accreditation? What do I mean with that? Summative, that's accountability, showing that externally and building trust. Formative is the learning capability. How do you combine external transparency with internal learning on the level of the individual professional? Again, there's no country in the world that has really figured that out, but it's something you have to keep in mind if you want to optimize your processes. So let me share with you some findings of a European research project that try to look more in depth in the quality improvement activities within hospitals. It's called DUKE, Deepening Our Understanding on Quality Assurance in European Hospitals. It's coordinated by a group in Spain, and you see all the different groups that participated in this project over the past 4 years. No Scandinavian country, but nevertheless, you can infer whether the lessons learned in this program hold any truth for the Danish hospital system. This project looked at various quality strategies within hospitals. It looked at the development of quality management systems, and that's very much in line what you also do in your accreditation model. It tried to capture the external pressure the hospital has experienced, and that's accreditation, but also the extent there is public reporting in the country and whether quality is part of the contracting, of the financing of the hospital system. It looked at the quality governance. What is the role of the CEOs and the management in quality? What is the roles of physicians and nurses? How extensive are patient safety strategies set up? And what is the clinical quality improvements? It also looked at patient experiences and involvement. I now have to focus on some of the results, giving time limits, but all these results will come available in publications. There's a theme issue of the International Journal of Quality in Healthcare planned for beginning next year that should contain about 20 articles that describe the results. So my apologies if I'm just focusing on a few points which I think are relevant for your discussion today about accreditation. So in this project, we had, well, you see the countries, 8 countries. Every country we had 30 hospitals where we had loads of surveys to the professionals and the CEOs. We looked at administrative data, and in every country we went in depth in 12. Again with surveys, but also with patient chart reviews and external visits. That comes very close to an accreditation. Actually, the researchers were trained nurses, research nurses who went to the hospitals to obtain the information we wanted. These were hospitals with more than 130 beds, and we looked at 4 conditions. We looked at AMI, stroke, hip fracture, and deliveries. Now, briefly, I'll give you the conceptual model we looked at. Because if you start looking at a hospital, you have to conceptualize different levels and different dimensions. So we try to look at what is the external pressure on the hospitals. By asking the CEOs, what do you perceive as external pressure? Then on hospital level, we looked at the functioning of hospital governance, and we looked at the existence of quality management systems. And basically, you see, in the end, we ended up with three indices to measure that. And on the hospital level, we tried to see whether the maturity of these things was influenced by patient involvement, it's on the left, or by hospital culture or professional engagement. Then we drilled down to the level of pathways, mainly departmental level, and at the departments, we started looking whether the rudimentary forms of quality systems were in place. So basically, have you allocated responsibilities, specialized services? Have you protocols and standards on how care should be delivered, evidence-based organization? We specifically looked at patient safety, and we tried to figure out whether there was a feedback loop, whether there was actually audit in place and was documented. And on that level, again, we tried to see whether it was linked to patient involvement, pathway culture, and professionalism. And then finally, on the patient level, we tried to capture patient experiences, perceived patient safety, and clinical effectiveness. And as you see, we tried to do that on 4 disease areas. Now, some findings. We had in total 192 hospitals participating. You see, in some countries we had difficulties in the end of recruiting hospitals, but in some countries it went very well. And here on the right, you see the total number of surveys that were collected. So we have about 10,000 professionals that filled in the questionnaires, 6,500 patient surveys, a total of 9,000 patient charts were reviewed, 74 external visits were conducted, and from 182 hospitals we have the routine data, meaning can you report 30-day case fatality rate, and do you know the complication rate in your hip fractures, etc. Some findings. Well, what did we find when we tried to describe the quality management systems on hospital level? This should be quite familiar dimensions to you. Of course, the structuring is different than in your model, but we looked at, do you have policy documents? Is it monitored by the board? Do you train professionals? Do you have formal protocols for infection control? Do you have formal protocols for medication and patient handling? Do you assess processes actually? Can you actually monitor clinical care processes through indicators? Do you analyze the performance of professionals? Do you analyze patient feedback? And do you evaluate results? Overall, on a scale from 0 to 4, in 189 hospitals, you see here the scores. The highest, and I think, but my Danish is not perfect, but that's also what I saw on one of your slides. Infection control seems to be well assured, at least we see the activities. When it comes to actually demonstrating that you monitor care processes via indicators, it's less prevalent. The overall scores, you see that there is still room for improvement. This was our overall quality management system. It ranges from 0 to 27. The average score was 19, but we see a big standard deviation, meaning that we can really differentiate hospitals based on this index. These two indexes were actually based on the group of hospitals where we did an audit, so we could actually not just ask them, do you have a policy plan, we could actually see the policy plan. There we had an index with a range from 0 to 16, average 10, and when we looked at the clinical issue, it's an index from 0 to 14, average 8. As interesting is what you find on the pathway level, where we looked at these different levels, and of course the questions were slightly different for the different medical topics, AMI, stroke, hip fracture, and deliveries. But overall you see that, well, the protocol part seemed to be quite good, especially with deliveries and AMI and with stroke, when it comes to the real clinical review. So actually seeing whether in the hospital they use the data and then improve on that, the rates were lower. Overall, a descriptive level of what quality management systems were in place. For external pressure, as I said, we looked at different things, not just at accreditation, but we, by also speaking with the country coordinators, found out that yes, most countries have public information, but the way how it's integrated in the system differs. In all systems it's for building trust, but in some systems it's very much related to the agenda of the voice of patients, patient emancipation, that information should be available. And in some countries it's actually linked to the political vision on having more competition in healthcare, so that the information should be there because then patients have a better choice. And also the extent that performance elements are in contract and financing are different. For example, the Turkish hospitals, there's a whole system of pay for performance directly related to these indicators in place. Whether it functions and is a good system is another issue, but this is the way the Turkish government tries to run the public hospitals. And an inspectorate is now existing or emerging in most of the countries. One of the things we did is to ask the CEOs of the 184 hospitals what they thought was influencing them the most. So the greener, the more influence. And you have to bear in mind the type of countries we're talking about here, but you see that governmental policies on quality are in the majority of countries still considered of most influence. Also with inspection and legislation. Publication of results in the public domain is considered high. Accreditation for clinical training, that means specialization training, and the accreditation related to that is considered high. And hospital accreditation actually scores quite high. You see, 55 say that is one of our major pushes we perceive as important as external pressure for doing things. You see that it's very low for an ombudsman, what the hospital associations say, and access to funding and what technology assessment bodies say. Again, this is perceived pressure, but it tells you something about how hospital directors think about accreditation. Governance, we looked at what board of trustees are doing. Are they actually speaking about quality? Do they have reports? Do they use indicators? And we tried to figure out whether quality and safety was on the agenda of the quality management, the client council, and the employees representative council. And every time we asked, do you have minutes and how many times per year are you actually discussing this? Is it regularly on the agenda, and do you actually have, is it just incidents that you discuss, or do you have a structured way of using indicators to discuss the performance of your hospitals on quality, just as you do with your financial data? Bottom line, We will now publish a paper where we can show that management boards that have quality on their agenda in most or every meeting, so have frequent discussion of quality, have significant more developed quality systems in their hospitals. That's a clear association we found. When we looked at the implementation of patient safety strategies, and again this is summarizing lots of data, but the point I want to make here, most of the structural things seem to be in place. So promotional hand hygiene reminders and all defibrillators are subject to a documented program of maintenance and calibration by an engineer, and laboratory equipment exists in the ward. What is more interesting is to see that some of the more soft issues in patient safety, like ward staff receive formal feedback on analysis of reported adverse events, or during 2010 clinical review included analysis of reported adverse events, or there is a system to report adverse event to patients, it drops. So it seems that over the past years we have been able to, at least in these countries, to get the more structural things in place, but when you start looking at the more soft things and the feedback mechanisms, you get lower scores. Finally, what I want to share is we focused very much on the departmental level, and what we found here is that yes, there is a relation between how formalized you have your pathway and responsibilities, protocols, using indicators and feedback, how better we found as a dependent variable the outcomes in terms of the things that should be done. Well, these odds ratios are all pretty high, but the bottom line here is that we couldn't, very roughly we found if you push at the bottom we see movements at the hospital, but it's very important that the board starts talking about it and takes it up. The real change takes place on the departmental level. So if you want the shaking here to have any impact here, there should be links. There should be accountability of departments on the quality issues, and really we can demonstrate it. If you have more of these quality assurance mechanisms in place and it works, you really have better results as measured in your medical records. So, and again, Denmark is here to the left. I promise you the stroke story. These are the more macro data that can help to underpin that. So let me come back to my suggestions for you to consider in the further improvement of your accreditation model. Because again, Denmark is at the top of countries that have developed quality strategies, and you are in the position that you work with a lot of the stakeholders together to have a Danish quality model, but how can you make it even better to adapt to the challenges you are seeing? Well, that means, of course, broadening, and as always, those are political processes, but it is important that you keep trying to do that you don't just go in the niche of the hospitals because that is there and start ignoring the rest of the system, because the rest of the system is where a lot of the pressure will be in the coming time. The alignment with policies on patient safety and performance indicators, yes, that's again using the data that are available, which performance indicators are you using, and when it comes to patient safety, and I saw a lot of alignment between the national efforts, adverse reporting, and the accreditation, but it takes continuous checking to see whether they're actually one and the same thing, and especially when it comes to, and that has to do with a more population-based approach. When I was last year in Denmark and I saw what on the departmental level is done by the Danish Health and Medicines Agency in terms of standard development, they have a very pathway approach, but it was very difficult to see how those standards and that thinking was actually reflected in measurement efforts on regional level or reflected in accreditation models. So that's seeing how there is an alignment between these different initiatives. And last but surely not least, the good thing of the Danish model is that you have huge stakeholder involvement. You have the involvement of patient organizations, the medical association, of the management, and of course that's the strength. But it also shows you, in the last point, where the weakness is. Because the bad story would be that on the coming 10 years, your Danish quality model becomes in in a niche bureaucracy, focusing only on hospitals, staying and perfectioning the model they have now, without really touching the heart and souls of the people working in the hospital. That is possible. I've seen other accreditation models that went that way, and then, yes, then it's a high price you pay for a lot of political energy and time. The real challenge will be to see whether you can position it in such a way that it is actually used for quality improvements, that it makes the links and accreditation with improvements on the departmental level, and at the end of the day, with the continuous professional development of professionals. I think you're in an excellent position to try to achieve this, given the fact that you are with the various stakeholders, with the patient organizations, with the professionals to do that, and I sincerely hope you succeed in adapting these things and making the system not just strong for what it is at the moment, but also sufficiently strong for the coming decade. Thank you very much.
Thank you very much, Nick. We have 15 minutes for questions. Who would like to start? I will start, Nick.
Okay.
In your Duke study, were you able, beneath those results you presented, to identify or trace any features at the various accreditation systems you must have seen that had more or less beneficial impact on the care delivered in hospitals?
The short answer is no. And that's,
I was afraid so.
That's partly because we had 8 countries. So, and in total 180 hospitals. So you don't have sufficient variation also in accreditation models to do it. There will be one of the papers, Charles Shaw will be the author of that, where we try to explore it, and we could see that we established a relation between external pressure and maturity of quality systems. You can't drill down accreditation to real clinical outcomes. On the other hand, I would have been surprised if that was the case, if I can just push a button here that all of a sudden things start moving here. I think what this project tried to do is try to unravel part of the black box and show how things relate to each other, and yes, that you have to work on different sides. So no ultimate truth on which accreditation model works or doesn't work, but insights in where you should look for figuring out whether your model has an impact.
Yep, thank you. Any other questions? It doesn't seem so.
It doesn't seem so. It's all up. Oh, you see? No.
Mogens,
You have to.
vi skal bruge herover. Mogens har der her.
Yeah, Mogens Hørder. As far as I remember, rather low on the list of what was functioning was the pressure from professional bodies, from associations of professionals.
Yeah.
I'm quite amazed to see that, because it's my impression that at least what we experience, and also what I see in, for example, England, is that the importance of the professional bodies are quite clear.
Yes, you're right. Well, it has hospital associations there. The professional chambers were quietly higher, but you have to bear in mind the 8 countries that were in this project. So you have to keep in mind that this is also about the Czech Republic, Spain, Portugal, Turkey, where the role of medical professionals association is different. But in those countries, giving that in the perspective of the 180 CEOs, you see when you ask them about the role of professional chambers, 15 very green and 42. So it's not that low. Also has to do with how much initiatives do these associations actually take. So when I take it to the Czech Republic and Turkey, 2 countries that also had a country review by the OECD, I know that there are far less activities in terms of organized guideline development or debating the further structuring of continuous medical education than in some of the other countries. There were questions there.
Tredje bagerste række.
I'm Marita Christensen from Neurocenter Hammel, and you point out one of the largest gaps and the biggest challenges in quality, and that is the patient's way through different sectors, from hospital to community and inter-hospital relationships. You pointed out as a challenge in Denmark, and I just wondered, do you have any very good ideas or something you saw in other countries that would be an inspiration of how to overcome this gap?
Okay, if I had a golden bullet, I would probably be rich. It's of course very system dependent, but there are some structural components there. So how have you organized things? If you have integrated delivery systems, like in some niches of the United States. So I have one organization that is organizing a hospital, a group of GPs, community care, home care, in one delivery system, Veterans Administration of Kaiser Permanente. Yeah, then it's easier to do things. That's not a reality in Denmark, and I'm not saying that you should try to strive there, but that's one determinant. Can you try to govern the whole integrated system? And if it's not done by structure, then you can try to do it by contracting or by financial alignment. So many countries have tried to introduce bundled payment initiatives where you say, well, I'm not going to reimburse diabetes care in the hospital, I'm going to reimburse diabetes care. And please come to me. Also in my own country, the Netherlands, we have bundled care arrangements, and a lot of the diabetes care for the minor patients has been taken over by the primary care. So the GPs had to organize themselves and work together with the laboratories to become unities that were able to contract. So in principle, either the organization is there, if that is not a feasible option, you can try to do it via contracting or financing, but you can put some incentives in place to help the providers to align their work. The other, of course, is to focus on pathways if you look at indicators. And that's exactly why I say that the accreditation program should be sensitive to that. It doesn't have to have indicators for everything, but you can make part of your accreditation standards how receptive and responsive is this hospital for the community needs where it's built. So is that part of your standards? Are you actually looking at that? Do you look at the context width? Because then you're using also this mechanism as one of the ways to trying to strengthen these linkages. And a very important one is the information infrastructure. And one of the things we found in our review is that whilst you have a very well-developed system of registries and administrative data in hospitals, in primary care, although there is a good project existing, but it's under development. And especially the linkages between all that is also an area to look at. So another thing would be to look at how your information infrastructure can actually underpin what you're doing. And, well, last but surely not least is of course the patient and the community themselves. If they start putting pressure on that and being critical on those aspects of the system, it can be improved. But bear in mind, I'm now giving you only examples of how to align the hospital with the primary care system. There are even as much challenges in aligning hospital and primary care system on the one hand with mental health care or with social care and long-term care. So yes, it's not simple, but there are ways in structuring financial incentives, guidelines and indicators and information systems that can help you to support different providers to work together.
Can I just for fun see the hands of those present who believe that if 25 Danish hospitals had been included in the Duke study, would have shown government policy on quality as having the most impact at all on their quality? Who agrees with that or who believes that? One.
Okay, could I ask the other question? Would you have thought if we would have asked this to you, that the Danish quality model and the concerted effort of all your organization, that was the most important one?
What is the most important one?
You see, people. No, there is not a most important one. What is important is what you perceive important. So, and again, with quality, that's why I put the public reporting there. I've seen now in several systems that the pure fact that things were in the public domain or there was an uproar, that caused a kind of dynamics that made it possible to introduce changes. I've also seen, in the UK or in England, for example, that putting that on the fore and making it the Strategy report is the most recent one, it has taken away a lot of the control from the professional bodies in the hands of government-related agencies. So that's another thing. And again, if it hasn't happened, it will happen. These kind of moments will also exist in the Danish healthcare system. And yes, then it is to you who picks it up and who kind of capitalizes on the moment for innovation that emerges.
A final question? Yes.
I'm Jesper Gjørup from CFK in Aarhus. This comparing between countries, it's a difficult matter. And as I understand you, you've been a bit pragmatic in OECD. What is comparable? What data do we got to compare? If you were to decide what kind of data you could get from the countries, what results indicators would you prefer to compare which healthcare systems are the best? You understand?
Yes, I understand, and I totally sympathize with you because I've been involved in this program since more than 10 years now. So yes, we're very much aware of the limitations of the data. For example, it's still a shortcoming that you have to speak about the performance of primary care without having good data from the primary care itself. So the OECD has to relate to all administrative databases of hospitals for potential preventable admissions, and in the past 2 years we start with work on prescription data, which seems to be the other area where most of the countries have a database, but really comparable administrative databases on primary care are very scarce. There are good examples, but they are scarce. So one of the strategies that OECD is taking now is on the one hand to work on indicators, and actually we just had 2 days meetings last week where we reassessed all the indicators and chosen the ones we want to work on from the coming years, and there the story is better a few of them good than having more and more and more and more. But the alternative story is try to look at the data infrastructure in the member states. So we are speaking a lot with governments about their linkage capability and how they set up their electronic health records, and if they actually think about the secondary data use in the electronic health records. And there again, Denmark is amongst the better group when we made an inventory last year about the amount of projects you have ongoing that use data linkage between databases, registries, etc., and electronic health records. That's better than some of the other member states where it's either forbidden or hardly there. But it's one of the consequences. If you don't work on improving your data infrastructures to capture the continuous care for patients, you won't be able to govern your systems.
Thank you, Nick. I think it is time. Thank you very much, Nick.
Thank you very much.
The next speaker is a real heavyweight in the international world of accreditation. Wendy Nicklin from Accreditation Canada is president and CEO of one of the biggest accreditation organizations in the world, and one of the organizations that probably have the most... Oh, I'm sorry, I forgot lunch. Der er frokost en time. Sådan. I was I was carried away.